Yes, thank you. So I'm a health economist. I'm going to talk about the proof of concept work we did, and I'd like to start with acknowledging Borislava Mikhailova, who is my main collaborator in all stages of the work. So in case you're not familiar with the context, so a health policy model is a tool that helps inform policy decision by projecting people's life courses. So the possible predictions it can make, can be disease events, life expectancy, quality of life, healthcare costs, as well as effects of treatments. And effects of treatments can be positive, so disease risk reduction, but also negative, so for example, treatment side effects. And the key point is that projections can be made over a long time period and often over people's lifetimes. Why maybe we want a health policy model? So as you know, healthcare budgets are limited, particularly in the country like UK, where we have universal healthcare. And therefore, because of the opportunity cost, not all treatments can be recommended, even if they are effective. So therefore, we use so health policy makers and clinicians have been increasingly using policy models like this to show whether treatments are good value for money. And in UK, we actually have to provide some cost effectiveness analysis when recommending the treatment for funding for use. And as you may know, we have an arbitrary threshold of 30,000 pounds per extra quality adjusted life year. So the modelers always look for this magic number when they do this analysis. And if we have a flexible model, it can answer many questions. So there's quite a lot at stake when we do the models. So therefore, we aim for things like transparency, reliability, reproducibility, obviously, and of course, usability as well. So how can we make our model used by other people? So it's really the last part, the usability, that I'm going to talk about, but I will talk about other things as well briefly. Okay, so this slide tells me that I should have followed the example of my fellow presenters and saved my PowerPoint and PDF because my smileys look different in my laptop, although maybe because it's French PowerPoint. But anyway, so how can we achieve all of this? So we can release the code, as this is obviously in the spirit of this community, but it doesn't actually going to help with usability because to use the code, people do need to possess quite advanced R skills. And there is a lot of potential as well to misuse the code because it's quite a complex code. So misuse can be intentional, but also unintentional, especially if people want to adapt the models for their own use, for their own contexts. We can obviously, the absolute minimum is to publish equations and methods so that other people can reproduce the code in the language of their choice. But again, it doesn't help with usability because it does require some programming skills. Okay, so what we did, the obvious answer is produce a user-friendly interface, Shiny in this context. So this is what we did, and also we published the methods and the equations in a paper, and we accompanied the paper by the Shiny app, which I'm going to present you. So that's the front page. So hopefully I'll be able to show you some live demo in a minute of our model. But just before that, I'll just very briefly describe what our model actually does so that we know what we're doing. So it's a model in chronic kidney disease. So it's a fairly common disease, particularly in elderly population, and it's a progressive disease, but it also increases cardiovascular risk. So what we wanted to project long-term outcomes in patients with kidney disease. And the outcomes included cardiovascular events, kidney disease progression, life expectancy, quality of life adjusted life expectancy, and healthcare costs. And on top of this, we also wanted to enable implementation of treatments that reduce cardiovascular risk, so for example, statins. So the ultimate goal of this project, the eventual goal of this project, was to assess cost effectiveness of such interventions. Okay, so I'm not going to give you much detail at all about what we've done, but essentially we had a patient-level data from a trial. We didn't actually have a problem with messy data. It was very nice data. We had a bunch of characteristics on baseline characteristics, so social demographics, comorbidities, a bunch of risk factors. We have time-updated variables. We used all this data to fit in some risk equations, and then we put the risk equations together in a Markov model to calculate transition probabilities and do lifelong projections. Okay, and we validated the model. Okay, so everything I showed you on the previous slide, everything that fitted on the previous slide, by the end of the project, I was 3 years older and had my first child. So it was a massive undertaking. So obviously, once the model was out, we wanted it to be used by other people. Okay, so the sort of users we had in mind would be other analysts or clinicians. And this is the people who don't normally use R, not because they can't, but because they have other equally important priorities. Okay, so we're aiming for a user-friendly interface you can access from anywhere, no need to use R. But in addition, we also wanted not just people to use the model as is, but also to be able to adapt it to their settings. So the type of settings you can think of is, so for example, you want to look at the projections in a different country. So this one had some parameters based on UK healthcare system, but maybe you want to adapt it to France or to Sweden. And so you may want to change parameters such as national mortality rates or healthcare costs. Or maybe you want to apply it in UK or another country, but you want to change different parameters. So for example, different treatments. So you want to assess the cost effectiveness of atorvastatin or maybe PCSK9 instead of simvastatin. Or you may want to run it for different types of population, or you may want to play around to see how duration of treatment affects your outcome. Or other sensitivity analysis you might want to do, because there is a lot of uncertainty involved in these models because we extrapolate often over very long periods of time. So one thing people do is to see how robust your conclusions are to a range of sensitivity analysis. Okay, so I'm sure I don't need to sell Shiny to this audience, so I'm just going to hope that this link works. I have a backup slides as well. Okay, so it does. Okay, so this is the front page of our interface. So you see we have a bunch of options on the left. Okay, so on the first page we put description and also links to the most important things. So we have a very detailed user guide. We have a link to the paper in which all the methods are published, and a contact email address, which has been used, I can tell you. Okay, so then we have some glossary. Because a lot of input and output is CSV files, because obviously this is a friendly format for outside users, for external users, we provide some example files, both for input and for the output as well. So we show them how the output file looks as well. And we have very detailed specification of all of this in the user guide. So for the input file, we explain exactly which columns need to be present in the CSV file, what are the permissible values. And for the output files, we explain exactly which every column means, because there is quite a lot of information in the model outputs. Okay, and I should say that we have default values. We've implemented default values for all of this, for all parameters, so that people can, so the model is actually executable. You don't actually need to enter anything to see what the output looks like, but obviously you can change a lot of things. So you can decide on the type of analysis you want to do. So either projections or the cost effectiveness analysis. You can you can do uncertainty or not do uncertainty. If you do uncertainty, you can sort of specify how precise your uncertainty you want to be. The way you enter patient characteristics, you can do it in two ways. So one way is just to use the drop-down menus. Okay, and you can see, this is actually, by the way, this is my first Shiny project, and last so far as well. Okay, so I spent, I think that was a couple of hours of my time was just spent just to see how to do the superscripts, how to learn how to do the superscripts in Shiny, but I'm quite happy with the result. Okay, one of the hardest, probably the hardest thing I found on this project was to do some sort of field validation, because of course the person who enters, we wanted to prevent some type of data entry errors. Okay, so we had to do some field validation. Okay, that is a French keeper thing. Okay, I can't input negative numbers, but I can show you a number outside of it. No, I can't. Ah. Okay, well, that's not permissible either, to be honest. So that's fine. It doesn't matter, to be honest. The point was, oh, thank you. I can reset, so I can't. Yeah, no, it's fine. I can reset. Okay, so the point says that if you do some values that are outside of the range, or for example, non-numeric values, as you've seen, it works. If you input non-numeric values in a numeric field, it gives you an error message. There's some more complex conditions as well. So, for example, if you have somebody who is diagnosed with diabetic nephropathy, they must have a diabetes flag as well at baseline. So if you don't specify them as having diabetes, you will get an error message. Okay. Most importantly, until you get rid of all the messages, you can't actually run the file. Okay. So this is obviously not completely foolproof, but it does require people to think. Okay. So you can't just just mindlessly press the run button. Okay. And if you have more than one patient, so you can import CSV file with with many lines, with data on many patients, or just one patient. You can do it. You can do it using a separate option. And again, we implemented some data check in there as well. So it was a bit more obviously. We had to do it more because we had to check that every column that's required is there, the names are correct, and the values are permissible as well. Okay, the combinations of values as well. Okay, and then what other things we have? So we can, thank you. So user can enter some sort of treatment parameters. So you can enter your treatment parameters for your treatments of your choice on a bunch of different outcomes, so cardiovascular death, and so on. You can enter uncertainty, you can enter standard errors around your estimates if you do uncertainty analysis or not. If you don't, so you don't have this field, so if you don't need uncertainty. And we thought of other parameters that might be useful for clinicians. So for example, compliance with treatment percentage, treatment cost, because we look at cost effectiveness analysis, and other things. So you can change your healthcare costs. And as I said, there are default values for most parameters. They are not actually random, so this is based on the data from our trial. So this does give you interpretable valid results. And other things as well. So you can change quality of life estimates, you can change decision parameters, type of simulation you're using, and so on. And if all goes well, you might even be able to see the results. And if not, I blame the French internet. See, what can possibly go wrong in a live demonstration? Yes, okay, okay, so I did cost effectiveness analysis, okay. Okay, yeah, so this is the output we have. So we have some sort of events, so this is this is a very high level output, so it's just some sort of event rates for the groups that didn't take the treatments, group that did take the treatment. Okay, you can discount it, undiscount it. Okay, and this is very low, high level output, but we have much more, obviously. We have the costs, we have the quality of life, and you can download all this in a CSV packs summary. Okay, so how do I go back? Oh, yeah, okay, thank you. And these are my backup slides. You see, it's actually very similar to what I've done. And just the last one to show, we can actually do uncertainty. I didn't run it here because it's quite time consuming, but we can actually produce uncertainty estimates, confidence intervals, and lovely ggplot graphs. Okay, so hopefully this sort of tool can help other people, non-R users, to use the interface. But just quickly, I think it also helps with things like debugging and transparency as well. So you can very easily do some sort of face validity debugging. So I don't know, set treatment effect to 0, compare life expectancy of patients with diabetes versus those without diabetes, see whether the results actually make sense. But of course, also the more easy it is to use the model, the more people are going to use it, and the more people are going to find mistakes. So you get more feedback. And we have actually had people coming back to us and saying, because you normally get negative feedback, nobody comes back to you if everything works. So you normally get all those grumpy comments about why this doesn't work. Okay, and sometimes it was a user error, and sometimes we did actually once discover a bug in our implementation. Okay, so I think it's very helpful both ways. And just one last thing I wanted to say, if you have several models in the disease area, you can actually, what you can do, you can run several models against a reference simulation. And this is an initiative I took part in, I was invited to take part in last year, Mountford Diabetes Challenge. So this is a sort of group of people do modeling in diabetes that come together. So this was not a diabetes model, but it had a diabetes flag. So I was allowed to take part because I could predict output for diabetes patients. Also, this was the last week of my maternity, so I was very happy to leave the house for several days and several nights. Okay, so the idea is that everybody gets the same task. So we have a reference simulation. So we are told to predict some sort of an outcome for a predefined patient. Say a woman, 60-year-old, who is a non-smoker, and so on. And we have to document all our assumptions in a predefined template. And we run the simulation, and we produce the results, and we compare them, and we discuss them at the meeting, and we often publish them as well. So we've actually just had a paper accepted 2 days ago that argues that these sort of things do help transparency. And of course, you can do it from within R, but it's very easy to do it in user-friendly interface. And also, it's very easy to replicate results as well for other people. Okay, so as I said, so just to conclude, so we have an interface, and also we've published the methods and equations, which hopefully makes it quite easy and sort of transparent for other people to use the model. It's very modifiable, it's very flexible, and we try to use user's perspective into account. Okay, so we try to provide the detailed user guide, example files, default values. We try to do field validation as well, to prevent some inappropriate use, okay? And of course, once we have the model out, we need to support it. So we need to reply to queries, to fix bugs. We need to fight with our IT team, who constantly insist on updating R, which of course breaks everything. And also, I probably shouldn't be saying this in our conference, but I'm not quite sure whether R is the best option for such an interface. It's great for modeling, but might it be faster if I use something else? I don't know, Python, C++. Should we release the code? We haven't, but should we release the code? Might the benefits of releasing the code outweigh the risks? I don't know. Okay, so if anybody has any views, I'll be very happy to discuss it. And I'd just like to acknowledge some other collaborators that help us with development of the model, the funders, and thank you very much.
Thank you for the talk. I'm wondering, what do you think are the risks of, you mentioned, should we release the code? Do the benefits outweigh the risks? What do you think the risks are?
Well, I mean, one is obviously people just scoop, people just steal your fame. But I think that's probably not even necessarily. I mean, the main risk I see is because this sort of model, people very rarely use these models as they are. Usually they modify them. And when they modify them, they can say anything. They can say, oh, we've used this model to produce these results. And of course, these results matter a lot. There's kind of, they said, oh, we produced this, we got this, our treatment is cost effective at 19,000, just below the threshold. And it's kind of, they can do it intentionally. I mean, you can just sort of fit the model, just play with the parameters so that you get the answer you want. But also, they can do it unintentionally as well, because it's a very complex code. I mean, there's like tens of thousands of lines of codes here. So you kind of, I don't really see much point in releasing the code, because either you understand it all, and if you understand it all, you might as well just recode it, because it's probably not even very well coded, to be honest. Or you don't understand, and if you don't understand it, maybe you shouldn't be using it. You see, so it's kind of more like what people do with the code. But what I'm thinking possibly in the future, maybe not release the code as such, because we did actually have, so we started organizing this initiative in London, R, sort of bringing R to health economists, because that's sort of, again, that's not very widely used in the health economics community, and modeling as well. I mean, lots of people still use Excel for these sort of things. And we discussed it in detail last year. So what we came to a conclusion, maybe it's not helpful to release the code, but rather package the individual snippets, because there's a lot of sort of little processes involved, like how to produce this ggplot, this CR curve, how to do the transition probability in the Markov model and so on. So not to release the code as such, but just to release in individual steps. So that I might actually do. I don't need the funding for that though. But I would like to apply some funding to do that eventually, yes.
All right, thanks a lot. I think we'll have our next speaker.